Gaiti, can you make it live? Yes, yes, ma'am. Yeah, ma'am. Now we are on live, ma'am. And let me share the screen. Yeah.
Okay.
Yeah. So we are starting session, ma'am. So very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. It's about the perinatal awareness webinar arranged by Aurangabad Society and Proxy Pedagogy Committee. I welcome the chief guest. I welcome the participants. I welcome the speakers, chairpersons for today's session. Now I would like to welcome the MOC, that is Madam for today's session, Dr. Sharda Parikar, ma'am. Madam is the clinical secretary of Aurangabad OG Society. With the short introduction, I welcome you, ma'am. I'm handing the session to you for further proceedings, ma'am.
Thank you so much. I welcome all of you for the Perinatal Awareness Webinar conducted by Aurangabad OBGYN Society and Foxy in Union. I invite and I welcome Dr. Veena Panet, ma'am. Let's start with today's session. The first speaker we have today is our respected Chinmay Ratha, ma'am. She is presently director and lead consultant of fetal medicine at Hyderabad. And she has been chairperson of Foxy Perinatology Community 2021-23, member representative of AICC RCOG in 2021-23 again, and various posts like treasurer and chairperson of Fetal Medicine Committee. She has been recipient of very prestigious awards like APJ Abdul Kalam Award for Medical Excellence 2021, Dr. Rajat Ray Fetal Medicine Award Foxy 2021. The Wonder Foxian Award 2019, the Foxy Young Author Award, and many more. I welcome you, ma'am. Kindly proceed with the lecture.
Shraddha, Dr. Lakshmi Madam, she will be chairing this session.
Let us just hear something from Bipin sir. Bipin sir is our vice president and who has taken out time to be with us.
Yes.
So I would want sir to declare the program open for us, and the chairpersons to say a few words before we move on to the academic part of it.
Yes, yes, ma'am.
Thank you very much. Thank you, Chinmay, and all the team and faculty from all over in Aurangabad, and my dear friend, Dr. Mane and Madam Lakshmi. And it's a great pleasure to be with you here. And of course, today is a feast of lectures and very good speakers going to speak about perinatology, the field of maternal and fetal medicines, one of the most rapidly evolving and growing field in medicine, especially with respect to the fetus. A lot of research is being carried out on this field, and many young gynecologists are joining this field and making a lot of difference in the life of unborn fetus. And today the fetus is considered as a patient, and it is really becoming bigger and bigger, and a lot of prenatal treatment is going on, intrauterine transfusion, and the latest thing is gene therapy and stem therapy in fetus, and correction of fetal defects, and so much is on the plate. So hopefully this is going to be a very good lecture, and I'm sure Chinmay and all of the faculty members will do a great justice. I wish you all the best, and thank you very much for inviting me. Thank you.
Thank you.
Thank you,
sir. Shraddha, Dr. Lakshmi Madam is there as chairperson. Just welcome her.
I welcome Dr. Bipin Pandit sir once again. Sir is director of Mukund Hospital. I had the opportunity to learn from him as a student at Nanavati Hospital, if you remember, sir. Sir is vice president Foxy 2021-22 and past president MOX 2018 and 19. Sir has been chairperson and speaker at various conferences. I welcome you, sir. The other chairperson we have today is from Aurangabad OBGYN Society, Dr. Lakshmi Rachakonda ma'am. She is professor and head of the department at MGM Medical College, Aurangabad. She was past president of Aurangabad OBGYN Society, treasurer amongst at UA Foxy Endo World, has been awarded ICUG Fellowship and has presented various papers in FIGO, Brazil, published many papers, and has been faculty in national and international conferences. I welcome you both, ma'am.
Thank you, Shraddha.
I kindly request Chinmay Ratha, ma'am, to kindly proceed with the topic.
Thank you so much. At the outset, I would like to thank Dr. Veena for taking this initiative and making this happen, because perinatal awareness is something which we are trying to spread as part of the Perinatology Committee workshop activities. And we, with the blessings of Dr. Vipin and Dr. Lakshmi, let's start with the academic session, because it's not just pure academics that is going to take us forward in our mission of perinatal awareness, but understanding the application of all the theoretical things that we learn in how to reframe our practice. For example, today we have fetal growth restriction as one of the topics where we are going to talk about antenatal intervention, when to intervene in fetal growth restriction. And then we'll have Kedar sir talk about, how a neonatologist is going to look into that situation. What is the neonatology care that is required in an obstetric setup where you are going to handle patients with specific requirements. And again, not to forget the medico-legal aspects or the important, inputs that are required to keep yourself, your patient, everybody safe in that do no harm, venture that we have taken up in medicine. So I hope we all do justice to our topics. Thank you very much for giving me the opportunity to speak on this fetal growth restriction and when to intervene. As always, this is a very, very, dear topic to any fetal medicine specialist, and fetal growth or growth in general has to be something dear to all of us, because, like this gentleman said, life is growth. If we stop growing, technically and spiritually, we are as good as dead. And this is very nicely represented in fetal life, where, every day there is growth, and there is growth from a single cell into a full human being. And anytime there is a loss of that potential to grow, or there is a restriction in that growth curve, things can go as bad as death. So there is a risk of intrauterine fetal death if fetal growth restriction is not identified or not handled properly. I would not use the word treated, because honestly, we do not have a treatment for fetal growth restriction. We only have management of fetal growth restriction. So one of the first things that occurs is understanding that growth is a continuous process. And then how you approach growth restriction is to identify growth restriction by identifying those fetuses which are unable to reach their genetically predetermined growth potential. So if a fetus is not achieving that growth potential, it is called growth restricted. How will you know this is growth restricted? First and foremost, establish correct dating. Match the biometry to that dating. If the biometry is falling apart despite the dating being correct, then there is growth restriction. And that is done by ultrasound. And then you do Dopplers, amniotic fluid assessment, placenta, and other features to quantify or, sort of prognosticate that growth restriction scenario. Now, what we know now is there are two types of growth restriction, which is early onset growth restriction and late onset growth restriction, both of which lead to a lesser growth in the baby, but it is more stark in early onset growth restriction and subtle in late onset. However, the impact on the fetus is more it can be very bad in both of them. So even the late onset growth restriction, where the actual biometric compromise may not be that much, can still have a risk of increased morbidity and mortality. So the problem in fetal growth restriction is fetus is unable to grow inside the uterine cavity. And in early growth restriction, we know that the placenta is very small, and therefore it is not able to provide enough nutrients to the baby. And in that case, you see serial changes in Dopplers, like, the umbilical artery becomes high resistance, absent flow, and then reverse flow. There are venous changes. Whereas in late growth restriction, the placenta is not small. It is okay. It is normal size, but the maturity is bad. So the functional effect of the placenta becomes restricted. And what happens is, although the biometry may not fall that low, there will be a definite change in the cerebroplacental ratio, because the MCA Doppler will be slightly changing, the umbilical will be slightly changing, and the biometry will start falling in terms of centiles. It still may not be an SGA. So understanding this concept of the early and late onset IOGR is very important, because then only you know how to intervene. So in early onset IUGR, the problems are more in the placental circulation because the resistance in the placental circulation is high. And that is what helps us understand the importance of the various Dopplers that we do. So we do the umbilical artery Doppler because the umbilical artery is the peripheral circulation of the baby, where the hypogastric arteries continue as umbilical arteries and carry blood from the fetus to the placenta. So the organ pumping blood in the umbilical artery is the fetal heart, and it is pumping against the placenta. So when the placental resistance increases, the umbilical artery blood flow shows poor diastolic flow, then absent diastolic flow, and then reverse diastolic flow. So umbilical artery is a representation of placental resistance. The ductus venosus is the inflow of oxygenated blood into the baby. So it's a continuation of the umbilical vein. Just before it joins the fetal heart, you have a vessel called ductus venosus. So the ductus venosus Dopplers represent how much oxygenated blood is coming into the baby. So when that gets compromised, the baby will move into anaerobic metabolism and will land up in acidosis. The middle cerebral artery is a vessel which is arising from the proximal parts of the aorta and contains as much oxygenated blood as is possible in systemic circulation, which goes directly to the brain and supplies about 80% of the fetal brain. So if the middle cerebral artery has low resistance, that means there is cerebral vasodilatation, which will usually occur after hypoxia. So the middle cerebral artery is taken as a surrogate marker for fetal hypoxia. So this is how we start looking at the fetal Dopplers to classify the stage or the functional disturbance in fetal growth restriction. So now we clearly know that we have classified growth restriction into early and late, and now we will decide how to intervene, when to intervene, and what is the rationale behind that intervention. So as a ballpark figure, 32 weeks is taken as the gestation to classify early and late. Now remember, just because you diagnose growth restriction at 34 weeks, it doesn't make it late IUGR. It may be a late detection of early IUGR. So to say that this is late IUGR, you should know that till 32 weeks, the baby did not have growth restriction, and thereafter that has started. So it is a good idea to have one growth scan at 32 weeks to distinguish early versus late IUGR. So this is a pregnancy report. If you see that at around 24 weeks, all the parameters are less than 5th centile. And here you have also redated the pregnancy. Despite the correction, there is severe symmetrical growth restriction. So this is an early onset IUGR, and you think of the common problems like aneuploidies, infections, very early onset fetal uteroplacental insufficiency, or even maternal nutritional compromise. Sometimes when you look at the placenta, it looks large, jelly-like. When I say large placenta, it may not be a large healthy placenta. The villi may be less than that. There may be very bald villi in there, but that placenta is not going to function like a good placenta. The volume of the placenta does not correlate with the function of the placenta. So in these kind of conditions, you may have a picture where it's a 22-week fetus with severe growth restriction, with absent or reverse diastolic flow in the umbilical artery, where MCA and DV are still okay, but the estimated fetal weight is less than 3rd centile. So at 22 weeks, less than 3rd centile will be something like 100 to 200 grams. At this situation, can we intervene? Can we do anything? We cannot do anything. So we just ask them to come back for a review. If the mother's condition is okay, just follow it up. And this patient, when she was followed up at 26 weeks, there was an IUFT. And there was nothing that one could do to circumvent that outcome because the picture overall is so bad. Now, this is another lady who was 30 years old, Gravida 3, Para 1, where, she has a low PAPE in the first trimester. A low PAPE in the first trimester is an indication of a poor placental function, but it's also a marker for aneuploidy. So she had a lot of, tests for fetal aneuploidy that was also sorted out. And there was distinct history of the poor maternal nutritional intake. So here nutrition was changed, and if you see, the baby continued to grow along lower centiles, but there was steady growth on serial scans. So serial biometry was reassuring. And despite the fact that she had low PAPE, despite the fact that her initial assessment for growth restriction was very high risk. She continued having a steady growth restriction and a steady growth, interval growth, and she delivered a 2.7 kg baby at 38 weeks with good monitoring. So here we didn't have to intervene in terms of delivering the baby, but management was better because there was a known cause that there was poor maternal intake, and that changed the outlook of the pregnancy. Similarly, this is a case where there was low PAPA, 0.27. Anything less than 0.4 is considered as low PAPA. There was increased resistance in uterine arteries. The umbilical artery Dopplers were bad, and everything was against her. You know, her age was 45 years. Everything seemed to be bad. So here, when you look at serial biometry, you see the abdominal circumference falling off charts. So this is the way of monitoring fetal growth restriction, where you keep doing your serial biometry and see the trend of the change in the outcome. So what is happening here is high placental resistance, and the umbilical changes are predominating. Detection is very easy. This is early onset IUGR. My diagnosis is absolutely correct. The problem is, how do I manage it? Because it's so early in pregnancy and so bad in terms of Dopplers that if I don't do anything, probably there will be an IUFD. If I do something, I will land up in the NICU in a very, very precarious situation, and I don't know what to do. So this is another pregnancy where, you know, at 18 weeks only, there was a 9th centile growth. At 25 weeks, there was a 6th centile growth. But with good monitoring, this just continued because the Dopplers were normal. The umbilical resistance was just high resistance, positive diastolic flow. And somehow she managed to reach 36 weeks. Although the baby was only 1.8 kgs, at 36 weeks, delivered for reduced fetal movements and had a good outcome. So in cases of fetal growth restriction, your intervention will depend on how are the Dopplers. So like here, the Dopplers remain normal, just high resistance, but positive diastolic flow. So we could just serially continue it and take it to almost 36 weeks. Late onset growth restriction is a different ball game altogether because it starts after 32 weeks. The growth pattern may be normal till then, but thereafter there's a sudden change in the growth pattern, and there is a potentially severe implication like even fetal death in utero, because the placenta is not, I mean, the maturity is poor, but the fetus does not have any compensatory mechanisms in place. So suddenly when things become worse there you may have an unexplained intrauterine fetal death. So that is why identifying late onset IUGR is very important, where you look at the fetal growth parameters and see that if there is a tapering of the growth centiles in the 3rd trimester, then it is called as a late onset growth restriction. And it results from the failure of the placenta to supply adequate nutrients and oxygen to a rapidly growing late gestation fetus. And this kind of a diagnosis is quite difficult unless you're looking at serial biometry very carefully. So what we require in serial biometry is fall in the fetal weight by more than 2 quartiles. So just like we do centiles where we divide the data into 100 parts, quartiles is dividing the data into 4 parts. So suppose there is a difference of 2 quartiles in the change in whatever is the growth parameter, then we identify it as a significant growth restriction in the 3rd trimester. And this is exactly what I was telling you, that in the early onset IUGR, you will have small placenta with less number of villi. In late onset IUGR, you'll actually have more villi, but the villi maturation will be poor. So, you know, you won't pick this up unless you're looking for it very, very carefully. So just as an example, I have taken this, that early onset and late onset are like 2 students. Early onset is like a poor student who has very poor grades always, you know, C, D, 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 C. So this is always known to be somebody who is at risk of failing the exam, and everybody is careful about this. The parents are taking care, they're doing extra coaching. And suppose this baby fails also, everybody is prepared that, okay, the student might fail. Whereas late onset IUGR is like a good student who has good grades in the beginning of the semester, and then for some reason gets distracted in the final semester and even fails the final exam. So this is a student whom nobody expected would fail, and nobody is therefore ready to accept that failure because it's an unanticipated failure. So for late onset IUGR, unless the obstetrician is very, very careful and looking at it, you may have an unexpected intrauterine fetal death, which you can't explain. Most of the time people say, oh, it was not even IUGR, but you don't know if it was a late IUGR, because late IUGR will not be a SGA baby. So here you will not find the classical changes of Doppler like you see in early IUGR, but you will see just mild alteration in the cerebroplacental ratio. The umbilical artery Doppler may be slightly high resistant. The middle cerebral artery may be slightly low resistance, but the cerebroplacental ratio would significantly alter. So whatever happens in the fetal system during IUGR is a continuum of placental disease, hypoxia, acidosis, and death. So all these Doppler changes represent these changes at different levels. And when the worst part happens, the acidosis and death scenario, prior to that, you will see changes in the CTG, changes in the biophysical profile. But those kind of monitoring methods don't give you a lot of time. If these things are abnormal, you have to deliver the baby immediately. Suppose there's a baby with a poor biophysical score. What do? You'll have to actually think of immediate delivery because this baby is otherwise getting compromised inside. So while these are good methods of monitoring, waiting for a biophysical profile to worsen for delivering the baby would require a lot of other preparations in place, because you may just have to deliver the baby anytime the biophysical profile is abnormal. So you don't have time to call your neonatologist or give steroids. It's a given that all these things in the background will be ready. Whereas if you're using Dopplers to predict the onset, time for intervention, then you have time. You know that today umbilical artery is absent diastolic flow. It will take me about a week before things get worse, and then you take it to that point. Is there a treatment for IUGR? No, there is actually no treatment for IUGR. You can just manage things which are wrong. If the mother herself is ill, you can treat the mother. If the fetus has infections, you can treat the fetus. But mostly it is because of placental reasons, and there is no treatment for these placental reasons. A quick word about sildenafil. Phosphodiesterase inhibitors were always thought to be improving placental circulation, but after the Dutch tried a study, there has been a clear-cut safety warning against the use of sildenafil in pregnancy for purposes of growth restriction, because that leads to problem. Bipin sir was just talking about gene therapy. Well, fetal gene therapy is still in a very, very nascent stage, but one thing which may happen is this, the Everest trial, where they are doing the vascular endothelial growth factor injection into the maternal uterine arteries at a time to express the VEGF better and help in better placentation. There's a trial going on. The results are still not out, but this is also an adenovirus containing VEGF gene that is being injected into the maternal circulation to help form better placentas. If that happens, probably we will have some answer to preventing growth restrictions in certain cases. But as of now, it is still an ongoing process. These treatments standard do not work. That is what is given in our literature. The thing is, when we keep telling patients that nothing works in IUGR, it's a very, very frustrating situation. So it is like you're damned if you do and you're damned if you don't. So to screen ourselves with that do no harm protocol, there are some things which really don't harm us. For example, if we improve maternal nutrition, it will not harm us. If you improve, at least optimize the rest to 2 hours in the day and 8 hours in the night, that will not harm us. If you give her oral hydration, that will not harm us. If you help her maintain a fetal kick count, that will not harm. Regular antenatal checkup, at least weekly or twice weekly Dopplers as needed. Counsel and prepare the NICU and deliver at an optimal gestational age, balancing that hypoxia and acidosis. So the timing of delivery when the GRID trial was done was based on these Dopplers. And I think it's not really changed a lot with this new stage-based management, because the concept remains the same. You have to balance gestational age versus the worsening Dopplers. So in this new stage-based balance protocol, if you see that is given here, when you have severe smallness or mild placental insufficiency, the umbilical Dopplers are just about, say, high resistance, not really bad. You can take the pregnancy to 37 weeks and even do a labor induction. But if you have absent or reverse diastolic flow, then you start thinking of earlier gestation. So absent diastolic flow, 34 weeks, reverse diastolic flow, 30 weeks. And if there's a DV abnormality, then even at 26 weeks, you have to either think of delivery or giving up on that baby. Because if you don't deliver with a DV abnormality, you're looking at impending fetal death. Now, the thing about this is hypoxia is something which will probably be part of a growth restriction scenario because you can't prevent it. There is some degree of suboptimal oxygenation associated. And hypoxia-related changes lead to reversible neurological morbidity. But acidosis-related changes lead to irreversible neurological morbidity. So our challenge in fetal growth restriction is to intervene between the hypoxia and acidosis and lead to not only survival, but also intact survival. So following the protocol which we saw here, where we classify the growth into severe smallness, severe placental insufficiency, low suspicion of acidosis, and high suspicion of acidosis, we then decide which time to intervene. So whether it is 37 weeks, 34 weeks, 30 weeks, or 26 weeks, it goes according to the protocol of what exactly are the problems we are seeing. And our target therefore remains to balance the odds and to do an early diagnosis of fetal growth restriction, appropriate monitoring, and timely delivery so that we prevent preventable morbidity and mortality in the same pursuit like I started with, where the goal remains do no harm. Thank you very much for a very patient hearing.
Thank you so much, ma'am, for the very informative lecture. Any questions from the doctors? Or should we take at the end of the session? I welcome Dr. Anuradha Shevale, ma'am. She is the president of Aurangabad Obgyn Society, and she is director of Shevale Hospital and Ajanta Fertility Center in Aurangabad, practicing IVF and endoscopy since last 20 years. She was a founder member of MSR President Aurangabad Obgyn Society, and Foxy recognized. She is running a Foxy recognized training center for ART and infertility. I welcome you, ma'am.
Hello.
Yes, ma'am.
Audible?
Evening.
Yes,
Yes. Good evening.
Thank you for giving me this opportunity. Actually, I was a little late for joining. So let us continue. It was a wonderful lecture by Dr. Chinmay.
Chinmay madam, it was very excellent lecture. I think the concept of that student whom we are anticipating was very nice, very nicely explained.
Thank you. Thank you.
But that early failure, we can correlate very nicely, and that gene therapy, which is coming up, a very new thing. And really, it's very difficult for us. And when we are not anticipating, we feel that it's no FGR, wrong date. It becomes very difficult. Very nicely presented. Thank you, ma'am. Thank you.
Thank you, madam. Thank you.
Thank you.
Thank you, ma'am. I welcome Dr. Ajay Mane, sir. Sir is a member of National Inspection and Monitoring Committee, PCPNDT wing, and has been chairperson of various committees like Official Amox website, Sexual Medicine Committee, chairperson of Adolescent Health Education Committee, Amox. Sir was past president of Aurangabad Obgyn Society, ex-superintendent of MGM Medical College, Aurangabad, has been trainer at various Foxy Adolescent Health Committee. We welcome you, sir.
I think Dr. Shraddha, we are
Yes,
having
ma'am.
Dr. Kedar sir's lecture first, and then
Yes.
we can wind up with, we have a complete medical legal thing. Then.
Fine. Yes. So I welcome our next speaker, Dr. Kedar Saveshwar, sir. Sir is an ex-associate professor of GMC Aurangabad, has been a national mentor at Laksha program, Government of India, was national faculty at NRP India, and also at Development and Supportive Care Foundation for Newborn and Children India. Sir was a founding member of National Coach, Nationwide Quality of Care Network India, National Instructor at FBNC India, National Faculty at NEST India. I welcome you, sir. Sir's topic today is care of the neonate in obstetric setup.
Thank you, Shraddha.
Yes.
And thank you, everybody, for inviting me for this talk. I will just share my screen. Screen is visible now?
Yes, sir.
Yes, sir, it's visible.
Yeah. It was a long felt need for me as practicing neonatologist to present this talk to all the obstetricians in our region regarding care of neonate in the obstetric setup. So all of us know that millions of newborns die as a result of birth asphyxia, infections, complications of prematurity, and the burden is quite high. It's almost 80% in the low middle income group countries like India. And as a result, the care given immediately after birth is crucial for making it a successful transition from intrauterine to extrauterine function and to reduce the neonatal morbidity and mortality. So as you can see from this diagram, 44% of under 5 mortality is related to neonatal deaths. And among that neonatal deaths, complications of premature birth contribute 35%, intrapartum related events contribute to 24%, sepsis and meningitis 15%, pneumonia 5%, and congenital anomalies 9%. So a major chunk is prematurity and intrapartum related. The flow of today's presentation will be care around birth, that is delivery room care or the golden hour care in the wards. So those babies who are in the obstetric unit, but they need some monitoring. When to discharge a newborn from the obstetric unit, and what are the interventions which helps to improve the neonatal outcomes, and what are the quality improvement opportunities to improve our care outcomes and how to implement them. So care around birth, that is the golden hour care, is very, very important and a major contributor to the neonatal morbidity and mortalities. And this care encompasses not only the emergency care around birth, that is the resuscitation, but also the essential newborn care at birth and till the baby is admitted in the obstetric wards. So resuscitation, of course, I am not going to teach or discuss details about the steps of resuscitation, but I'm going to highlight certain issues which might affect our outcome related to the events occurring at the time of birth. So basically, we need to have a greater anticipation which baby might need expert available at the time of birth, like those who are IUGR, those who are preterms, those who are having fetal distress or a fetal compromise, those with having suspected and congenital anomalies. So on all these occasions, we need to have expert neonatologists present at the time of resuscitation. Coming to equipments which should be available in the labor room or OT for the resuscitation includes not only the bag and mask or ET tube and laryngoscope and oxygen source, but when we are anticipating birth, which is preterm birth, especially the extreme preterm or a very preterm birth, less than 32, less than 28 weeks, considering that these babies might land up later on in chronic lung disease of prematurity, we need to have certain additional resources like a TPS resuscitator and oxygen blender, air oxygen blender. So these are going to affect and the delivery room CPAP. So these are going to affect the long-term outcomes. So nowadays we have increasingly treating extremely low birth weight babies. So all these factors definitely matter in the long run as far as the morbidity and mortality is concerned in these babies. We need to have skilled persons or preferably a team when we are expecting a resuscitation for a baby who is going to be born. So by skilled person, I mean the one who is trained in NRP and who is regularly updating the NRP certification. And a team at times for especially a very compromised baby or a very extreme preterm baby, presence of at least 2 people is needed, preferably 4, but at least 2 people skilled in resuscitation is needed. And of course, when we are expecting the baby is likely to land up in problems, land up in NICU, and if time permits, we can have antenatal counseling of the parents so that they are prepared very well in advance regarding the future course of the baby. The essential newborn care at birth includes the delayed cord clamping, immediate drying, skin-to-skin touch, breastfeeding, vitamin K, weighing, cord care, and eye ointment. So we'll discuss one by one. Delayed cord clamping. By delayed cord clamping means delaying the clamping of the cord after the delivery by at least 1 minute. So preferably between 1 to 3 minutes. Now, what are the advantages? Why should we delay the cord clamping? For a term baby, it results in higher hemoglobin at 4 to 12 months and improved iron stores. There is improved survival in malaria endemic regions if you delay the cord clamping. And also, it has been found to have better rates of exclusive breastfeeding in those babies who receive delayed cord clamping. These babies tend to have a better heel and palm temperature, meaning that they are less likely to suffer from cold stress or the mild hypothermia. For preterm babies, it results in higher circulating blood volumes, lesser blood transfusion during an ICU stay, better systemic blood pressure, reduced need for inotropes, higher cerebral oxygenation index, and lower frequency of any intracranial fluids. Significant advantage, especially in VLBWs and ELBWs. So we need to practice the delayed cord clamping. Coming to skin touch after birth. So by meaning of skin to skin touch after birth is the baby is delivered on mother's abdomen. They dried there if required. Suction is also done there. In otherwise, baby who does not require resuscitation, she has to be delivered on the mother's abdomen. Dry there, cover the baby there. Allow the baby and mother contact, skin to skin touch contact for at least 1 hour. During this time, baby does a breast crawl and starts breastfeeding on its own, searches for the nipple and starts breastfeeding. And this skin to skin touch after birth for 1 hour has a lot of benefits both to the baby as well as to the mother. To the baby, it maintains normothermia. The baby adapts better to the external environment. It results in colonization with maternal flora rather than the hospital flora. It promotes breastfeeding, results in better sleep for the baby, and the baby is cryless. For the mother, the benefits are in terms of lesser anxiety, less fatigue, less breast engorgement, greater self-confidence and bonding with the baby, less blood loss, better involution of uterus, shorter hospital stay, and higher pain threshold. So we have seen, actually I have seen many places they are trying to do a skin-to-skin touch after birth, but it is done for say 15 minutes, 10 minutes, 5 minutes. That is not the concept. The concept is to provide 1 hour complete skin-to-skin touch for these babies. Vitamin K must be administered to all babies delivered irrespective of their birth weight or gestation. 0.5 to 1 milligram intramuscular. It has been found to reduce the chances of hemorrhagic disease of the newborn, and especially for those babies who are at risk of early hemorrhagic disease of the newborn. For example, those mothers who are receiving phenytoin, phenobarbital, or primidone. Vitamin K must be observed, must be administered immediately after birth, and a dose has to be repeated after 24 hours. So, and in such mothers who are receiving these drugs, maternal vitamin K 10 milligram can be given 24 hours before delivery to prevent this early hemorrhagic disease of the newborn. So in case the baby is having bleeding, we need to investigate with PTA, PTT. A thorough clinical examination, preferably by a neonatologist, or in the absence of neonatologist, by the obstetrician should be done in the form of Apgar score at birth, then monitor the vital parameters, the heart rate, respiratory rate, the color, the activity. If required, you do suction and observe signs of respiratory distress in the labor room itself. So also the importance of clinical examination lies in ruling out congenital malformations, that is by doing orifice counting and looking for their patterns. Now, coming to care in the ward. So the babies which are likely to be staying with the mother in the obstetric unit are usually the term healthy babies, or those babies who are more than 35-week gestation and are stable. Babies having birth weight more than 1.8 kgs, babies who had a little bit of mild perinatal asphyxia, needed just stimulation or less than 1 minute positive pressure ventilation by bag and mask, or babies like infant of diabetic mother in a well-controlled diabetes, and baby is appropriate for gestational age. So these kind of babies are usually, they stay with the mother, and they need some monitoring because they are likely to have some issues related to nutrition, related to perinatal asphyxia. They might land up later on with respiratory distress, hypothermia, hypoglycemia, jaundice, early onset sepsis risk is there in certain situations. Some babies may have a dehydration fever because of inadequate feeding. And when it becomes pretty severe, they may later on land up with hypernatremic dehydration. So we are going to discuss about these situations. So coming to nutrition, I'm not going to discuss the advantages of breastfeeding and all that, how to do that. But what I have found most of the types is two things. One is the inverted nipple issues, which might be taken care of during the last trimester probably. And the second is once the baby is born, the issues related to proper breastfeeding. One thing I would like to highlight here is what are the 4 signs of good attachment, that is the latching of the baby. And these are, so whenever baby is properly attached, you will see only more areola is only visible at the above the baby's mouth than below. Baby's mouth is wide open, the lower lip is turned outward, that is everted, and the baby's chin is touching the breast. So this you can easily see from the picture here what is a good attachment and what is a poor attachment. So once there is a good attachment, there is proper feeding of the baby, and you don't have to use formulas in such situation if you are able to establish feeding within the first hour of birth, especially. So another issue related to the feeding is adequacy of feeding. How to assess the adequacy of feeding? So whenever we take rounds during the postnatal care, we need to ask the mother or the attending grandmother or any other person which is a caretaker regarding adequacy of feeding by asking how many times you are feeding the baby, what is the amount of urine baby is passing, and how is the baby sleeping after feeds, for how long. So generally, if the baby is passing 6 to 8 urines in 24 hours, baby is sleeping between at least 2 to 3 hours between 2 feeds. That is how, and the weight loss which we see initially, that is the physiological weight loss, is usually up 1% or maximum 2% in a day. If it is more than 2% per day in the first few days of life, so maximum weight loss permissible, that is the physiological weight loss, is up to 10% in the first week of life. Then that ensures you the adequacy of feeding. Coming to mild perinatal asphyxia, so those babies who require a little bit of stimulation, suction, little bit of oxygen, or mild less than 1 minute of bag and mask ventilation support, but they are otherwise stable now, they are appearing well. Those babies will be kept with the mother, but they will need monitoring. You need to observe the activity of the baby, color of the baby, monitor the temperature, how is the baby feeding. And these babies are at risk of hypoglycemia, so we need to monitor their sugar levels for at least 24-48 hours. These babies are prone for hypothermia, hypoglycemia, poor feeding, and at times they may progress to hypoxic ischemic encephalopathy and land up in convulsions. So we need to ensure normothermia and prevent hypoglycemia by supervised feeding. So a staff who is trained in feeding has to supervise it and see to it that a baby is properly feeding or not, and report in case of any issues. At times we see the baby is born, it either a late preterm or there is a meconium stain like her, or it's an elective cesarean section. little bit done little early, so early term baby for maternal reasons. These babies may be having a good respiration at birth, but may land up after a few hours into respiratory distress like situation. So most of the causes are usually transient tachypnea of newborn, or some of the babies who are late preterm may land up in RDS. Meconium babies may appear well at birth, but sometimes they land up after a few hours, 6, 12, 24 hours, up to they can land up in respiratory distress. Congenital pneumonia babies may manifest with respiratory distress at a later stage, not immediately after birth. Spontaneous pneumothorax is known in the baby without otherwise risk factor, and that may land up in baby with a severe respiratory distress. At times, because of overzealous feeding, or sometimes the baby is late preterm, baby may land up in aspiration pneumonia as well. And if not properly managed, they may land up in hypothermia and hypoglycemia. So these babies also may land up in respiratory distress. So how to identify a respiratory distress? There will be tachypnea. Baby may have grunting. They may have increased work of breathing in the form of intercostal, subcostal, and sternal retraction, and baby may have obvious cyanosis. So these babies need a frequent monitoring, especially in the first 24 hours of life, with monitoring of respiratory rate, color, work of breathing, and preferably if you have a pulse ox, so check for pulse ox, maybe 6 hourly or 12 hourly, depending upon the situation. Now, if the baby lands up in respiratory distress, the babies will need an ICU admissions, but before the neonatologist comes and shifts the baby, we can stabilize the baby by doing suctioning if there are secretions, by administering oxygen by nasal prongs or hood under warmer, and properly transferring the baby in ambulance with all the facilities to an ICU. Hypothermia is pretty frequently seen, and contrary to our expectations, if we start monitoring rigorously, we will find out that almost 30 to 50% of babies will have some mild, degree of hypothermia, at least mild cold stress. So whenever the temperature is less than 36.5 degrees Celsius, it is termed as hypothermia. So there are different grades, mild, moderate, severe, based on the temperature. So anything between 35.9 to 36.5, it is mild. From 35.9 to 32, it is moderate, and less than 32 is severe. And most of the causes are related to the ambient temperature in either the labor room or the wards, or because of delayed feeding, baby lands in cold stress. Baby's clothing is not proper. That's why also baby lands up in cold stress. Some mildly asphyxiated baby also land up in hypothermia, late preterms, especially they are vulnerable for hypothermia. We need to monitor the axillary temperature of these babies at least at 1 hour, at 6 hours, 12 hours, and at least twice a day for at least next 48 to 72 hours till the baby shows you demonstrate the normal temperature frequently. There are certain gadgets available like Bempu watch, which will alert you the baby becomes hypothermia, but they are a little costly. Those who can afford, they can use this kind of watch. Why it is important to monitor hypothermia? Because if the baby becomes hypothermic, they can land up in respiratory distress, hypoglycemia, they may land up in apnea, late onset sepsis, and at times even convulsions. Managing this baby involves maintaining the ambient temperature of the labor room or the wards between 26 to 28 degrees Celsius. If you practice skin to skin touch after birth, or a KMC in the wards, especially for the late preterms, and warm clothing, you can easily prevent hypothermia. So you can put up this kind of posters in your wards and labor room, so that babies do not land up in hypothermia, and you can monitor them. Coming to hypoglycemia, for practical purposes, any blood sugar less than 45 milligram till 48 hours or less than 60 milligram after 48 hours should be labeled as hypoglycemia. Although babies have a nadir at about 1 hour of age, they may have a sugar which is less than 45, but once you feed them, they will demonstrate a rise in blood sugar, most of them. But some babies will be at risk for hypoglycemia, and we should screen them, say at 1 hour after first feed, and the first feed has to be within 1 hour after birth, and then pre-feed sugars every 6 hourly for 48 hours. These babies are the low birth weight or the late preterm babies, the HJ babies, the babies who had mild perinatal asphyxia, the infant of diabetic mother, the large for dead baby, and those baby mothers who receive medications like beta blocker, like labetalol. These the babies born to these mothers are prone for hypoglycemia. Usually, these babies may be asymptomatic initially, but they land up in problems like lethargy, poor feeding, respiratory distress, cyanosis, hypotonia, and if that is a prolonged severe hypoglycemia, they may land up in convulsions. And this is a preventable cause of cerebral palsy. So at all costs, we should monitor these babies and screen these babies for hypoglycemia. Management in the obstetrics basically involves proper feeding schedule, monitoring the sugar. And if the baby lands up in hypoglycemia, till the time baby is shifted, we can use dextrose gels, which are available in some cities, not in Aurangabad at present. So that's a buccal gel which you can give, which results in rise in blood sugar. Until the time the baby is shifted, we can tide over the situation, prevent the further complications. Those babies who have a symptomatic hypoglycemia or are unable to reach the target blood sugar, or if they setup lacks the monitoring facilities, will need admission to NICU. So this is a flow diagram which shows you how to manage the hypoglycemia. Coming to jaundice, any jaundice with the onset within 24 hours of birth is pathological jaundice. Commonest causes being RH incompatibility and ABO incompatibility. Physiological jaundice usually starts on day 3-4 onwards, and it rises till day 7 and comes back to normal by day 10. There can be situations where this physiological jaundice might get exacerbated because of, say, prematurity, low birth weight, polycythemia, mild perinatal asphyxia. So all these things exaggerate it, and which may need treatment. But there are certain high-risk neonates who needs to be screened for jaundice before being discharged from the obstetric setup, like the mother having O positive blood group and the baby having other than O, so ABO incompatibility. There is a history of previous sibling requiring treatment for jaundice. Infant of diabetic mother, SGA babies. So these are the babies who definitely need screening before discharge. And there are our specific nomograms available, which is shown in this figure. So based on the age in hours and total serum bilirubin, you can categorize them in whether there is a low risk zone, baby is in the low risk zone, or an intermediate risk zone, or a high risk zone. And based on that, a follow-up has to be arranged. In busy setups like medical colleges or big institute where number of deliveries are more, number of babies in the wards are more, it is practically difficult to do serum bilirubin for all these babies, where you can use transcutaneous bilirubinometry, and there are nomograms available based on transcutaneous bilirubinometry. You can then further do serum bilirubin if required. So because at times what we have seen is baby is discharged from the obstetric setup, and after a couple of days baby lands up with us, and with the bilirubin pretty high in the exchange range. RH incompatibility is there. Antenatally, IDCT is not done, but cord blood is sent, reports come, but is not communicated to the pediatrician. Report is positive, and on 12, 24, 36 hours after baby lands up with serum bilirubin in the 30s. So this has happened. So it's better to be aware about these situations, have proper communications with your neonatologist, and plan for this screening of high risk babies before discharge. Now coming to situations which predisposes baby for early onset sepsis. So those babies those mothers who are having PROM more than 24 hours, maternal fever, or those who have undergone unclean vaginal examination, then land up with you for deliveries. These are the babies who are at risk of developing this early onset sepsis. There are calculators available to find out the risk of early onset sepsis. You can use that also. But what is most important is currently the concept called triple I, infection, inflammation, or both. So you have to divide the based on the clinical situation, the babies into either mothers into either isolated maternal fever. So there's a documented fever of 39 degree or more on two occasions. And if there is only fever, no other risk factor, it is called isolated maternal fever. If there is a fever without a clear source plus baseline fetal tachycardia more than 160 for 10 minutes or longer, maternal white cell count greater than 15,000 in the absence of corticosteroids, or there is definite purulent fluid from the cervical os, it is called a suspected triple I. And if all of the above factors are present and there is amniocentesis prone infection through positive gram stain, low glucose or positive amniotic fluid culture, and a placental pathology revealing diagnostic features of infection, it is called confirmed triple I. These babies need monitoring even if they are asymptomatic and may need antibiotic based on this protocol. So if we restrict ourselves to the obstetric setup where more than 35 of the babies are usually there with the mother, so you have to consider whether the baby is well appearing or sick. So if it is a well appearing babies and with only a suspicion of triple I, then you can observe and then evaluate. If there is a confirmed triple I, you have to work up and treat. If the baby is not well appearing, then of course you have to work up and treat. So this is the management protocol for those babies who are having a risk of early onset sepsis. Coming to dehydration, fever, and hypernatremic dehydration. Most of the time in summers, on day 3, day 4, a baby has some fever. Otherwise, baby looks healthy, baby is feeding okay, there is slight weight loss. These are the babies having dehydration fever, which is lasting there for a couple of days, and with proper feeding and taking care of the environment, you can manage these babies. So, but if the baby doesn't have adequate feeding, then slowly the baby lands up in severe weight loss. It could be a sign of hypernatremic dehydration or sepsis which is evolving. So to prevent all this and to manage this in time, we need to monitor the urine output. So while on rounds, you need to ask about urine output, weigh the baby before discharge, check the percentage of weight loss. And if the weight loss is more than 10%, or if the baby is suspected of likely to have a sepsis, then baby needs NICU admissions. We have seen a lot of babies, especially in summer months, who land up in the second week, third week of life with severe hypernatremic dehydration. So the baby was 3 kg, now becomes 2 kg. Serum sodium has gone to 190, 210, like that situations at times with creatinine 15 and all. Just because the baby was not properly fed for a long time. So if we have to avoid this kind of situation, so we need to monitor these babies when in our setup, and prior to discharge, weigh the baby and check whether the weight loss is significant or is within physiological limits. There are certain
చాలా 3 packets ఉన్నాయి.
maternal
ఎందుకు అవన్నీ
transmissible infections.
తెస్తుంది కదా, 3 packets ఉన్నాయి అక్కడ, 30 days ఉన్నాయి.
Lakshmi madam, by mistake, I think your mic is open, is on.
Some of the maternal transmissible infections which can be taken care of in the obstetric setup are like we need to look for evidence of any congenital syphilis in the form of mucocutaneous rash, gray patches, papules, desquamation of arms and soles. This baby may land up in sepsis or exaggerated jaundice, anemia, lymphadenopathy, hepatosplenomegaly, and they can be very well treated with penicillins, which has become rare nowadays. Genital gonococcal infections, they end up in purulent conjunctivitis. So single dose of ceftriaxone 50 mg per kg, maximum dose 125 mg intramuscularly can be given, which take care of that. The mother is having history of genital herpes. So usually this baby becomes symptomatic on day 3 or day 3 to 10. And they may have skin or mouth vesicle conjunctivitis, they may land up in encephalitis or sepsis-like syndrome. So if they are having conjunctivitis, 3% acyclovir ointment can be used. And for symptomatic babies, they need IV acyclovir. You can do PCR to know the status of the baby, whether it is infected or not. Hepatitis B is pretty common situation where the mother is HBs antigen positive. And many times we do not have any idea about the viral load also. And we have to administer hepatitis B immunoglobulin within 12 hours of birth and vaccine also. That is very, very critical. If the mother is HIV positive, baby might need antiretroviral prophylaxis in the form of zidovudine and nevipirin for 6 to 12 weeks based on whether the mother opts for breastfeeding or not. If the mother is having active pulmonary tuberculosis, we need to defer the BCG vaccines and start INH prophylaxis 10 mg per kg for 6 months and then give the vaccines. So these are some of the situations which are common with the maternal transmissible infections. So coming to a very important aspect, discharging these term or late preterm babies which are there with the obstetric setup. So we need to have a checklist in which should incorporate following points, like maternal readiness. We need to find out whether the mother provides the routine care, including the feeding, confidently or not. Mother should demonstrate knowledge of how to identify a sick baby and when to seek the help. The psychosocial and environmental risk factors are assessed and a follow-up plan is arranged with the pediatricians. The physical examinations of the baby must be done by an experienced healthcare personnel, preferably a pediatrician. Document the birth weight, head circumference, and length of the baby, which is very important considering some of the future of some of the babies who might land up in later issues related to short stature. So having this data is very, very critical. Document normal stable temperature, heart rate, and respiration. Also document passage of urine and meconium. Do document definitely the weight loss, whether it is less than 10% or more than 10%. If it is more than 10%, that must be followed up with the pediatricians. Minimum 2 successful feeds we need to document that baby has taken. Assess whether there are any antenatal or perinatal risk factor and arrange for follow-up accordingly. Also find out the maternal serology status and whether we have taken care of that, like hepatitis B. And if circumcision has been done before discharge, then circumcision site bleeding has to be assessed and mother has to be informed regarding how to take care of the circumcision site. We can do certain tests and investigations before discharge, like a newborn screen, which must be sent at 24 hours of age. And if it is sent before 24 hours, we need to repeat it after 1 week. In the Western world, they are doing hearing assessment of all the babies, which is ideal. In some of the setups here, even in Aurangabad, like Healthcare Hospital is carrying out this hearing assessment before discharge. We can also do bilirubin screening especially if the high risk babies who are at risk of having significant jaundice, or if the baby looks clinically having significant jaundice at the time of discharge. Pulse oximetry to rule out critical congenital heart disease. I will just let you know in the next slide. details about it. We need to document whether baby has received vitamin K or not, and if prophylaxis for ophthalmia pneumothorax is indicated, that has been given or not. And immunizations like hepatitis B immunoglobulin, the mother is hepatitis B positive. So this is the checklist which we can follow at the time of discharge. Now coming to the interventions which improve the neonatal outcomes. So this in itself is a separate talk. So I'll just highlight some of the things like antenatal corticosteroid, dexa or betamethasone, to all the mother who are like to deliver between 24 or 34 weeks. And those mother both beyond 34 weeks also, it results in lesser respiratory morbidities, especially if they are undergoing elective cesarean section. So magnesium sulfate less than 32 weeks, it is useful to prevent moderate and severe CP. Some fetal therapies like giving vitamin K to mother to prevent early hemorrhagic disease of newborn, penicillin prophylaxis for GBS, antiretroviral therapy for HIV, folic acid for neural defect prevention, dexamethasone if the prior baby is having congenital adrenal hyperplasia, digoxin if fetal tachyarrhythmias are there, steroids if mother has a history of ITP, and intrauterine transfusion for RH isoimmunization. These are the therapies which are needed to improve the neonatal outcomes. Now coming to screening. So before discharge, we need to screen babies for congenital anomalies by doing OE5 counting and their patency. Thyroid screening, ideally all babies should undergo thyroid screening, but at least those whose mother are on thyroxine, it is a must. On day 4, preferably if you do thyroid screening, it will give you the most accurate reports. Metabolic screening, especially if not routinely done, at least for those having previous history of unexplained death or previous documented inborn errors of metabolism, we need to do that. Screening for critical congenital heart disease by using pulse oximetry. So this is done on day 2, that is after 24 hours of age and shortly before discharge if the baby is less than 24 hours of age. Check with the pulse oximetry in the right hand or foot. If the saturations are more than 95% and the difference between the right hand and foot is less than 3%, it is considered pass screen. And if it is not passed, you need to repeat the screen in 1 hour and again document it. If it still fails, again you repeat the screen after 1 hour and again document it if it is a pass screen or a failed screen. Failed screen needs further investigation to rule out critical congenital heart disease. Hearing screening, of course, we need to promote more and more. What are the potential signs of neonatal illness? That is the danger signals which we should be aware about. So these include temperature instability, change in activity. So baby has become lethargic. The baby was active previously. Baby is now refusing feeds. There is unusual skin color in the form of pallor, jaundice, plethora or mottling. The cardiac or respiratory rate is abnormal. So there is a extreme tachycardia or bradycardia, or there is a tachypnea. There is abdominal distension or bilious vomiting and gastric aspirate. There is excessive lethargy, sleepiness or hypotonia. Baby is having excessive jitteriness, irritability or abnormal movements in the form of convulsions. Baby has a delayed more than 24-hour or abnormal stools. 12 hours have gone and baby hasn't passed urine. That is a danger signal. And the weight change that is greater than expected, especially if it is more than 10% of birth. So these are all the potential danger signals which you need to be aware about. How to monitor these babies in the wards? So temperature should be documented and a normal temperature between 36.5 37.5 degrees Celsius. Anything which is below 36.5 or above 37.5 degrees Celsius warrants further investigations. Simple test is to put your dorsum of hand, one on the stomach and one on the palms or soles. If your palms and soles are colder comparative to the abdomen of the baby, then the baby is having cold stress. You can use its affordable Biometry watch, which will alert you in case of hypothermia. Assess the airway if there is a noisy breathing or there are secretions. Check for respiratory rate, which normally is between 40 to 60 per minute. Observe signs of respiratory distress in the form of tachypnea, or if there is any apnea, or there are retractions. Check for capillary refill time. So you press over the sternum for say 4 to 5 seconds and just release your finger rapidly and see in how much time there is a refilling occurring. So normally it is less than 3 seconds. If it is delayed, it may be because of hypothermia, hypoglycemia, or there may be sepsis setting in. Normal heart rate is between say 100 to 160 at rest, but if there is a persistent tachycardia, even in a silent baby, or there is bradycardia, and it needs urgent referral. Feeding usually 3-hourly or a semi-demand feeding can be followed. We need to assess the adequacy of feeding, whether the baby is passing urine at least 6 times in 24 hours, and there is no excessive weight loss. So look for danger signals, which we have just discussed just now. Communication is an important aspect of the care of these babies with the patient as well as with the neonatologist. So we need to keep everybody in the loop. We need to educate the patient and inform any issues related to this baby's care with the neonatologist. So there has to be good communication between the teams. It is good to monitor, chart the monitoring 6 to 12 hourly based on situations. And in case the baby needs referral, we need to stabilize the baby before by keeping the baby under warmer if the baby is hypothermic, or at least giving KMC if there is no warmer, or wrapping the baby properly. By doing blood sugar, you can rule out hypoglycemia and administer oxygen in case of respiratory distress, or if pulse ox is there if the baby saturation is less than 90. There are a lot of improvement opportunities. So if you start documenting your data, you can document, these are simple interventions where you can find out the quality of care and where we need to improve. Like a percentage of babies breastfed within 1 hour of birth, rates of exclusive breastfeeding at discharge, number of babies receiving skin to skin touch, number of babies becoming hypothermic at 1 hour of age, number of babies who receive vitamin K at birth. So these are all the documents, documentary issues which we can actually look at our care. They will give insight into the areas which need to the improvement. We know a lot of things. Our knowledge is increasing day by day. As you can see from the graph, what was yesterday, today, probably tomorrow, our knowledge will further increase with all these CMEs, conferences, workshops we conduct. But there is always a gap between what we know and what we do. And we need to bridge that gap if we want to improve. And we need to have some framework if you want to bridge that gap. And this is one framework that is called point of care quality improvement, which gives you this framework to improve your outcomes. So it consists of 4 steps, that is identifying a problem, forming a team, and writing an aim statement. Healthcare at best is a team phenomena. So we need to replace me with we if you want to improve the situations from current situations to better situations. So identifying a problem, forming a team, and writing an aim statement is the first step. Then you analyze the problem and measure the quality of care by indicators, which we have discussed just now, like similar indicators you can have. Then develop some change idea from the team, take input from the team, develop some change idea, test them on a smaller sample, and then escalate and implement them. and then sustain the improvement. So these are the 4 steps which we teach in the point of care quality improvement. Thank you very much for your kind listening. If you want to know more about point of care quality improvement, you can visit the website www.ntocncop.org. Thank you very much.
Thank you so much, sir, for the wonderful lecture. All the important topics are covered, and that will definitely help in our day-to-day practice. Any questions from the audience?
And I think Dr. Purnima Satoskar madam has also joined while the lecture was going on.
Yes, ma'am. I welcome Dr. Purnima Satoskar ma'am. She is a professor of SET GS Medical College, Bombay, head of the unit of and Fetal Medicine Fellowship Program, now Wadia Maternity Hospital, Bombay, and consultant at Jaslov Hospital and Research Center. Her areas of interest are fetal medicine, and she has been recipient of various prestigious awards like Hergobin Medical Foundation Fellowship 2000 and Beth Israel Deaconess Medical Center, Boston, USA, and has been recipient of Foxy Ethicon Traveling Fellowship in 2000 and many more publications she has to her credit in national and international journals. I welcome you, ma'am.
Thank you, Shraddha, for the very kind introduction. I think Kedar has covered very extensively that topic, and I don't know whether I missed the initial part because there was some problem in joining actually. So I think we as obstetricians also are responsible for preventing early onset sepsis. We need to be very particular about our PV examinations, not to do early rupture of membranes, because as we can see that the effects on the baby can be very serious. So I think we also all need to be aware of it.
Thank you. Yes, ma'am, your point is taken. Lakshmi madam, would you like to add something? Okay. I think we can have some questions. Dr. Kedar, I just wanted to know, with the peak summer season approaching, do you think still babies can have hypothermia? So we should be on the lookout even in summer months for hypothermia?
Absolutely. In fact, hypothermia is more common than hyperthermia even in summer months. So we need to be aware about the situations. Put up the ACs, close the windows in case. These babies, especially the late preterms or small 48 babies which are there, they do not have the sufficient subcutaneous fat and brown fat to maintain their temperature. And if you do not take proper care of them by having adequate clothing, then these babies also land up in hypothermia, and especially if the feeding is not taken properly, is not supervised feeding is not done in these high-risk babies, and they will utilize their energy to keep their warm, and they also land up in hypothermia and hypoglycemia. So it is very much needed even in summer months. Monitoring is an important aspect of keeping these baby healthy.
Okay. And Dr. Kedar, should we offer the newborn screening to each and every baby?
Ideally, yes. Minimum nowadays packages are available, 6 screen, 9 screen like these. They are now becoming day by day cheaper, from say few hundreds to a few thousand rupees. Ideally, as those who can afford, definitely at this moment we should offer them and get it done. And it is more or less important when the previous baby has been a case of IEM or an undiagnosed fetal deaths or neonatal deaths. In such situation, it must be done at all costs.
Okay.
I think at least a basic TSH can be done everywhere.
That is mandatory. TSH, hearing screen, I think there is no shortcut. Yeah. Therefore, TSH has to be done.
Okay. Okay. Thank you. Thank you, Kedar sir. Any more questions? I think we will have at the end of the session. And welcome, Dr. Purnima madam. A warm welcome to you also. Shraddha, I think.
Yes.
Please.
third lecture for today. The next speaker is Dr. Ajay Mane sir. I have already introduced him. His topic for today is medical legal issues in birth asphyxia, stillbirth, and periviable birth, sir. Welcome.
Thank you. Before I start, I can see Dr. Rajan Singh Pardeshi, sir. Can we have his blessings, please?
Hello, good afternoon.
Good afternoon, sir.
Good afternoon, everybody. I wish to congratulate Aurangabad OBGYN Society and especially Dr. Veena. She has taken very nice topic now for that perinatal awareness. And with the faculties like Chinmay Rath, Dr. Kedar, and Dr. Ajay Mane, I hope this webinar will be a successful one. I wish every success to this webinar. Thank you. Thank you so much. Thank you. And I wish every success to Dr. Ajay Mane for his future endeavor in Foxy election as Vice President Foxy election. Thank you. Thank you so much.
Thank you. Thank you, Pardeshi sir, so much. Thank you for your blessings and kind words. And I'm sure Ajay is going to come out with flying colors with all our support from not just Aurangabad and Maharashtra, but all over India, with the kind of support he has given to all gynecologists in the medical legal issue. Anybody, anywhere in the corner of a country they have faced, Ajay Mane has been there for them every time and each time. And we look forward to more help from you, Ajay.
Yep. Thank you. Thank you, Veena.
Okay.
And thank you, Pardeshi, sir. Thank you, Anuradha Shevale, madam, and Shraddha. Because I have just modified, because the topic which Veena has given me consists of very small, short topic basically. So I have added a few of the neighboring conditions. So that includes ELSS and labor also, because we can have some more conditions with this. I'll share. Prematurity is the today's main topic. So we have taken some of the conditions. Patient came with a pregnancy of full term for first time for delivery in labor, and her age is 17 years. POXO Act apply here. Here, if patient is not full term, she is a preterm also, we need to inform to the police as a POXO Act and all follow the protocols. And what are the protocols? You must inform the police in written format, have a receipt from them, document it. There must be a pediatrician at the time of delivery in your labor room. That is mandatory for you, because to take care of the baby, if the pediatrician is not there, it comes under the negligent act by yourself. So you need to have a pediatrician who is specialized in the care of the baby. That's why it is mandatory. That is the protocol. Do we need consent for labor? Yes. Can a patient give consent who is in active labor? No. And can a relative give consent for the patient? Yes. If the patient is in labor and pains, that is not valid consent, so relative can give. Uniform consent given by Foxy, they are very beautiful consent they have given in a book that is called as uniform consent. It is available on the website for everybody. Get it downloaded, use it by printing your hospital's name on the top of there, or have just stamp and use that. Page number 95 to 104 book, they explain about complete of labor. There they have mentioned, I will tell you where they have mentioned that consent for natural birth, instrument deliveries, they have mentioned that instrumental delivery, forceps, vacuum, ventus, all the drawbacks of forceps and ventus, then the crushing injuries, the fracture bones, because it is more common in premature babies, and premature babies are very difficult to be taken out while cesarean section also. So some of the consultants, they say that we cannot use ventus in the premature babies. Some of the consultants say we can use very easily, but it is difficult to use the vacuum in premature babies. And if you use and something goes wrong, then you are negligent on the part of doctor, basically. Okay. Then emergency cesarean section also. Why? For if it is a meconium stain or the prematurity, then the court will ask you whether was it preventable, and if you say yes, then the next question will be what you have done to prevent it, and then you need to say what you have done. And if it is not there on your document, that you can say 1, 2, 3, 4, 5, 6. These are the things to be done, and we have done. But the court will say, okay, show me where you have done. You need to write each and everything on the paper. Then and then only it is considered as you have done it. So that is the main problem. As all specific changes, cerebral palsy, and all the infections, it is to be considered. Then this is undertaking signature by the patient. Then IUFD, a case come with a G4P3L0 type 2 diabetes mellitus presents in 39 weeks with IUFD. I have had some out of topic also, IUFD on admission. And what the documents are, what we need to have documentation about what did not come for checkup, did not get the blood pressure, sugar done, did not take insulin as advised, and did not maintain fetal movement count as advised. Then we are free of litigation of the negligence. Okay. Same condition, patient came with IUFD with a primary with severe PH present at 39 weeks. She may come at 32 weeks, it becomes a premature IUD. Then again, we need to document the things. Whatever you advise during your ANC care, have to write it down on the paper. May not be having a patient signature there that these things have been explained to me. Just you are expert, you are obstetricians, you are treating the patient. Then if you write something on the paper, it is considered that it is correct, because you are not there to do forgery. It is the real written in the real says that patient's advice so and so, patient is not taking tablets. Just write down one sentence there, that will save you from thousands of the complications. Okay, next situation, patient in PPH. Okay, I will skip this. Do we need consent of cesarean section? Yes. And the same thing again, they have given all the things, positive, negative point, having the thing, not having the thing, what can be the consequences, negative consent, undertaking, and all the things. How many years do we need to maintain the record? Labor 21 years, any procedure 7 years, CMT 5 years, PCPNT 2 years, CPA 2 years. But maybe that if just think that case is cognizable and case can be taken, then the judge can take the case maybe after 3 or 4 years. So CPA is that way. Amendment is dangerous thing. Insurance, it is typing mistake. It's 1 year. It is not 7 years. Every year we need to have indemnity and hospital insurance, and the indemnity should include your staff activity also, because something done by the staff, say for an example, injection chloramphenicol is advised and the patient had been given patient chloroquine IV and patient succumbed, patient is dead. Then this is a criminal negligence, and criminal liability do not transfer from patient to owner or the treating doctor as a vicarious liability. Vicarious liability is for civil only, it is not for criminal liability. Then the insurance company will say that, no sir, we have the indemnity for you only, not for the staff. So while doing the indemnity, kindly include your staff also in the indemnity and have at least 1 crore indemnity for 2 to 3 incidences. The company people are there very clever. They will write down in one corner that it will be provided for 1 incidence only. But mind it, before signing, check that they have given 2 to 3 incidences and your staff is also covered. Unregistered patient came in early labor, not ready for any investigations, and asked for admission and delivery. Can we deny? Yes. It is unregistered patient, so no moral duty to get her admitted, and she is in early labor, so can be easily sent to other hospitals. But there are protocols to send the patient, send with the proper documentation, referral sheet must be there, send the patient with the consent, transferring consent must be taken, and referral letter should be given, and 1 accompanying person, maybe a nursing staff or a brother or a junior doctor, must go with the patient till the destination. Next situation, patient not registered patient with a routine follow-up came at full term in labor, insisting for normal delivery only, not ready for CS. Then record proper finding on admission, because she is not ready for cesarean section, which is needed because heart rate is fluctuating. If something goes wrong, the cerebral palsy and all the things which Kedar covered very well. So in those matters, we can produce that on admission, this was the condition. we advise, depending upon the partogram, the seizure was must at this situation because the patient was on right side of the action line, or maybe on the action line, right side of the other line, and the descent was not there. It was taking more than 6 hours, not 4 hours. Likewise, we can explain depending upon the partogram. Keep the fetal record, keep the CTG record, and this will save you in the court of law. That why you have not advised, sir. We have advised. Patient was not ready. We have taken negative consents, and we are safe. Whatever may be the consequences, but we are safe. Same situation, but patient is not ready to shift also. Then all the things and denial of shifting must be taken from the patient, that I am not going to get shifted from this hospital, and whatever the consequences, I am responsible. Then again, likewise, we can take this in premature also. If patient comes in a labor with 32 weeks or 30 weeks, and at that moment you can take the proper notes on admission. It is a 6 centimeter dilation or a 7 centimeter dilation. At that moment, you cannot do anything. You cannot revert back the dilatation or push back. So take the proper admission notes, put it on the paper and everything, so that we can plead ourselves in the court of law. Because something goes wrong, the prematurity was what Kedar has explained. Prematurity may go to any extent, from blindness to whatever. So we cannot do anything. So just have a proper documentation, all consents, and that will save you. Okay. Patient came with cord prolapse. Again, same documentation. Immediate cesarean section must be done. We never know the cord prolapse is since how many times, how many hours, how many minutes, how the patient came in rickshaw when the cord is compressed between the pelvic wall and the head of the baby. For how much time, the asphyxia, we don't know till the baby comes out. So your pediatrician must be there. The baby must be shifted to NICU, though seems normal, and under observation must be kept. Previous LACS keep a very close watch with the short intervals, as it may go for scar dehiscence and rupture and maternal and fetal morbidity. Patient came with a preterm in labor. What is the next step regarding documentation? Admission notes are very important, because basically on admission, what is the condition? It will save you. You have not done this, you have not done that, but it was taken place before admission, then you are safe. Likewise, previous papers, they are very important. What previous papers say? For an example, it is a preterm in labor and maybe a case of cervical incompetence. You have advised a cervical stitch, or you have advised the progesterone. Maybe patient is not keen to take the tablets, or patient is not keen to come for the routine NC checkup, or patient was not ready for the operation. Also, it was written on your all documents, and that will save you from the allegation that you have not taken proper care of the preterms, and due to you only the preterm baby came here, and the charges and the pediatrician and all the NICU atom, oxygen, everything. But that's why the previous papers were very important. So keep a copy of previous papers with you. Patient never brings the OPD paper with them when something goes wrong. Deliberately also they keep the papers with them. They don't give you. So have a habit of having one copy of your OPD paper keeping with you, and give the original copy to the patient, or have a scan copy and read. If you are giving a computerized prescription, take a copy in soft format and preserve it with you. Okay. Advice given by you in a written format. Time to time advice which you need to document, that this is advice to the patient. Patient is either not taking instructions, or patient is not following instructions. Time to time, that will save you from the problem. And all investigations, what Kedar has given the list of investigations and advice, all investigation must be done. A copy of investigation must be kept with you, because as I said, patient did not bring anything. So what is the sorry. Okay, did not diagnose it. What do you do to avoid the complications? The court will ask you, did you diagnose it? What did you do to avoid the complications? And what are the protocols? Basically, you need to follow all the protocols, because something goes wrong, you need to produce the protocols, you need to produce your papers, and they must match. If you have given the treatment regarding, or rather following the protocols, you are free of the charges of litigations of negligence. You are not negligent. You have followed the protocols, but the response from the body of the patient and the baby is not that which you expected. That is not dependent on your treatment. That is dependent on the body response. So same treatment given to two persons, one is responding, second is not responding. That is not within our hands. So give the proper protocol treatment, and actual documentation is very much important. Okay, Jacob Mehta case, the Supreme Court said, so long as the doctor follows a practice acceptable to the medical profession of that day, he cannot be held liable for the negligence. So a prudent doctor would do must have been done by a doctor is not a negligent, likewise it says. So if there is an allegation, what can be the remedies? Confirm checklists were correct, say the doctor, explaining the relatives in a scientific way. It should be taken time to time. Counseling must be done, and the signature of the patient and the relatives must be taken on the counseling format. Sorry. Out of court settlement can be done if you are grossly on negligent part. If you are not on gross negligent part, let them go to court. We can fight there with good documentation and good protocol and backup services like Foxy, Amox, and Pardisar, me. We can help at any moment if you are correct. And if you are negligent, then try for out of court settlement because you know what is the situation basically. The out of court settlement is Lok Adalat is the option. In Lok Adalat, the retired judge is there at district level, and he may decide the compensation, and the compensation is given through court. Then the patient will not be able to sue you in any court after that decree of that Lok Adalat. So, because court case lawyers charges ranging from 10 lakh to 40 lakhs and maybe more. Why more? Nowadays, there is one fashion came from Europe and America. No win, no fees basis. What does that mean? The lawyer will say to patient that let me have a case against the doctor. If I win, you give me certain percentage from that compensation, and if I lose, you don't need to give me anything. Patient thinks, okay, there is no loss. If I lose, no fees is to be given to the lawyer, and if I win, I'll give 10% or 15%. That is my benefit. So he will say, yes, go have a case against the doctor. This is the dangerous situations. So number of cases will increasing from henceforth. Okay, doctor must have a strong medical indemnity that I told you. Basically, section 304A of IPC deals with the criminal negligence. Shall be punished as 2 years of imprisonment. If the A is removed, it becomes a 304. That is a culpable homicide. So imprisonment up to 7 years or maybe up to 10 years. That is culpable homicide. It is non-intentional murder, and 304 is death by negligence. Defense of a doctor, contributory negligence means we must keep an eye on the patient. If they don't listen or they don't follow our instructions, write it down. And that writing is same. Duty discharge according to prevailing standards, produce the protocols, plead properly in the court of law, and then you are safe. An error of judgment, which is not helpful usually, basically, error of judgment means there are two close diagnoses. You have chosen one, and unfortunately, the second one is correct. That is error of judgment. But misdiagnosis is not an error of judgment. Okay, misdiagnosis is different, and error of judgment is different. Precautions against negligence is often written informed consent, develop good rapport with the patient and relatives. So give time, have a counseling properly with them, and counsel yourself. Don't always send your junior to counsel them, because junior may do the counseling proper or they may not give the answer properly, and the relative are agitated, rather irritated, and they may take revenge. Okay, we'll take. Likewise, it happens. So keep full, accurate, legible medical record. No refurbishment is done, so that is legible. Never guarantee 100% cure. Okay, and complications took place, then keep the reference ready for the court case. On lighter note, I have given this guarantee certificate, which is given by Dr. Mandal. He is a quack basically. He has given that I give the guarantee of 100% cure, which is not possible. Don't give this. So anticipate the complication and bad conditions of the patient. Be ready for the system-wise and preparedness, because if you anticipate, then you are ready for the complication treatment. If you are not anticipated the case, then add on such real incidences, you need to run from this corner to that corner, and your staff will run faster than you. Keep proper documentation, keep blood ready and cross-match, especially when patient is RH negative. Always keep a parallel system ready. Why? If Kedar is not available, neonatologist who can come to your hospital and take the baby to the hospital. Maybe his colleague, maybe his junior, or the hospital staff of the hospital. And the obstetrician also keep 1 or 2 obstetricians parallel and keep them informed that such and such patient admitted. As an when the patient got admitted, say for 30 weeks, patient admitted with a 5 centimeter dilatation. So you are waiting for the baby to come out. So inform Kedar at that time, sir, we have got a patient of 30 weeks or 31 weeks of 5 centimeter. She may deliver within 5 to 7 hours. So you be ready for the next action. Likewise, you must have a system with your hospital staff, and all keep documentation about, followed all protocols. That is very important. That is the only way out who can save you. Partogram is very important. Nothing was missed according to the prevalence standards, and which standards we use, either FOXI or ICOG or ACOG or WHO or RCOG. Okay. AMOX is not giving the standard system because FOXI has given very beautiful, and FOXI has emerged like anything. Nowadays, WHO asks whose guideline you are following, FOXI, oh, then it must be correct. Likewise, the academic level has grown up nowadays. Done everything according to the present situation and in anticipation to it is to be proved in the court of law. All consents with the proper procedure and documents are with the prevailing standards, and legitimate record. What is a legitimate record? No furbishment, no after adding. So keep an eye to record properly. Ask the pediatrician to write down every notes with the our papers. Take home messages, follow all protocols, document well, keep train staff, training and drills regularly, because with the drills you can train your staff, and the trained nurse must be retained with your hospital. Have a system in the hospital working pattern. Keep good relation with the colleagues and help them when needed. My number, woman in India. This is the woman empowerment, and kindly vote for me for the running elections. The elections are from 21st to 30th of the March. Today is the 24th, fourth day of election. So kindly vote for me. There are 2 votes for West Zone. One is for me, and second is your choice. Kindly vote for me. This is my humble request from my side. And again, thank you, Veena and Shield Healthcare and our Mother Vision Society for giving me the chance. Thank you very much.
Thank you so much, sir. All the important and practical points are covered as usual. And all the best, sir. We are with you. Over to you, ma'am.
An excellent talk by Dr. Mane. It demonstrates a lot of knowledge of the subject as well as many practical points what we have to actually do to prevent litigation. I congratulate him. Our support is there with him. I've already messaged him and I voted.
Yes, ma'am, got it. Thank you, madam. Thank you very much. Your vote and message is like Ashirwad for me. Thank you.
Best wishes, Ajay. Shivani madam, would you like to say something?
Actually, it was a very excellent lecture by Dr. Ajay Mane. I have one query. If the premature baby is delivered with you and the relatives and the patient is not ready to transfer the baby to the neonatologist, is it our responsibility? Because if the mother has undergone cesarean section, she'll stay with us for 5 days at least. Those 5 days the baby can succumb. So whose responsibility is it? How to tackle?
Yeah, basically, obviously, the responsibility lies with the patient and the relatives only. It is not our responsibility because we are not the reason for the prematurity. Okay, first thing. Second thing, we need to explain each and every consequence of the prematurity to the patient and the relatives. And if they are not ready, take a just denial for the action, or take a negative consent that we are not ready to go to for NICU admission and for the further admissions or treatment. So whatever consequences, we are responsible for that. Likewise, we can take an undertaking from them and we are safe, madam. That is not our responsibility.
But the violence, what about it? They can.
That is a different thing. Violence, we cannot avoid the violence nowadays. So that's why keep them informed. If you keep them informed from point of admission, this is a premature, you need to go to such and such center, or If you are not having money or you are not ready to go to private hospital, then start preparing to go to the government hospital, government setup, whatever you need to go. And if they are not ready to sign, we can have a video recording of that. If you are counseling the patient, have a video recording with your either CCTV camera with the audio recording, or with your phone also you can have a video recording. That is a proof that you have counseled everything to the patients and you are safe. And furthermore, if they become violent, then we need to have another agency, which we have routinely in Aurangabad. We have sent so many hospitals, we have saved so many hospitals. That is the illegal agency basically. But if the patients are behaving illegally, there is only way out to prevent ourselves by illegal ways only. Legal ways come afterwards. Police may come afterwards. We may go to court afterwards. But the injury, say for an example, that the resident doctor who lost his eye in Dhulia in the hospital violence, what we can do? The relative may go to the jail maybe for 3 years, but the eye lost is permanent injury. So we need to take care of ourselves in other manner, which is not there in legal ways. We need to have a Mounser-like system, which is there in Mumbai and Pune. That is proper. This is a answer in bracket. This is not legal answer. This is answer in bracket.
I know. Thank you, Ajay.
Thank you, ma'am.
Ajay, I have received a question, and supposing now with the MTP law being extended to 24 weeks, that is fine. But supposing if at around 20 to 32 weeks, or recently in the Calcutta High Court, they gave permission to do an MTP of a 34-week fetus.
Yes.
So when this fetus is born, the fetus is going to be living. It will be breathing, it will be having, everything will be there. So what do we do? We don't pay any attention to that baby?
Yes, basically, see, feticide, we have demanded to government that kindly permit us for the feticide. Just do the feticide, potassium permanganate, and the feticide procedure is done, and then the abortion is taken place. Likewise, if it would have been, it is a safe procedure. But till this moment, government has not given the permission. So, what is the remedy with us? Just we can have the abortion done and keep the baby at a corner of a labor room, or maybe whatever the room is there, and wait for the death of the baby. That is very laborious situation, laborious thing to say also to me. It is non-human thing basically. But how the court has given permission, I don't know. They don't need to go to court. Nowadays, we are having a medical board. If the pregnancy goes beyond 24 weeks, there is a medical board at each and every district level by government. And if the board is not there, we can go to the head of department of government medical college, gynecology department. They will form a board, and the board will decide within 3 days whether to abort or not. If they say yes, go for the abortion at private also. And if they say no, they have to fill the form D, which is denial form. And after that, within 5 days, we need to terminate the pregnancy. But terminating a pregnancy beyond that viability period, 28 weeks, is a very difficult situation for us also.
Okay.
Yes, ma'am, please.
Yeah, I've handled a number of these cases before the law, and generally the committee was that time only at JJ, so they would refer it to me as a fetal medicine expert to give a report on that condition, so that the judges could understand what that condition was. And right from the beginning, what I used to do is, after explaining the condition, I used to write over there that the RCOG guideline says that feticide has to be done.
Yeah.
And in that same report, I used to ask for permission of the feticide, and it has always been given by the court. So now whatever committees are there, if they want these precedents also, I can give those cases. Basically, they should liaise with the court, high court or something, and then get it from them. So it should not be a problem. We have always done feticide and then done the MTPs.
Okay.
Yeah, that is better option, madam, basically, because moving baby and live baby is very difficult situation.
But now, at the moment, now Vadia has formed a committee. I am not there in that committee. So I am out of the picture just now. I don't know how they are doing the reports. But right from the beginning, I had the habit of citing the RCOG guideline and giving it as a reference and saying that it is advised, and they never refuted that. Because they never went into the details. They basically just gave permission, and because what we sent to them had all.
Yeah, we always. Yes.
We always
We need that legal sentence from the authority, that is court, that feticide is allowed. First
Yes.
do the feticide and then have the abortion.
Yes.
Okay.
Correct.
Okay. Sure.
Yeah,
Thank
we can have the copies from you, madam. It will be better for us if you give the copies for
And then
our reference also.
then the committees can take the permission and they can start writing it also, no, along with the permission.
Yes, ma'am. Yes. It is now responsibility of the committee that they should allow for the feticide and then go for the abortion.
Yes.
Okay. Okay. So one more question, Ajay and Purnima madam, for both of you. Sometimes we come across fetuses with complex cardiac anomaly or something at a very early stage, at around 19-20 weeks, we see a congenital diaphragmatic hernia. Then we counsel the patients, we tell her that amnio is better to be done. And then we tell her that we can have a wait and watch policy. We can do the international protocol, keep a close follow-up, refer it to a tertiary center. Sometimes patients opt for termination of pregnancy. Sometimes patients opt for continuing their pregnancy and getting the delivery done at a tertiary center. So what kind of documentation do we need to keep about our counseling that we have done? Because sometimes if after all this, the fetus succumbs later or in the postnatal phase, then they may sue us and say, you should have offered MTP at that time. Yeah. So how do we counsel and how do we advise?
Purnima ma'am.
Yeah, so at the moment we are now running a perinatology clinic or a fetal medicine clinic, which is a multidisciplinary clinic at Wadia. And here both the husband and the wife sit down and then we talk to them. So there are several things which we have to consider. One is that the natural course of the condition, because some conditions are so bad that there is absolutely no hope. So they have to understand that. And some conditions are such where we give them based on our experiences on the data or the experiences in Children's Wadia Hospital, what are the survival rates. So we document all this. It is explained to them what is the natural course, what is the survival, how much handicap will the baby have. Then about the surgery, the surgeons tell them about the number of surgeries which will be required, what will be the morbidity, success rate and everything. There's a complete counseling and at the end of it then everybody signs. Or at least I sign and the couple signs,
Obviously, that is there.
This is documented properly and this becomes very important in cardiac. So now we have actually cardiac clinic where, the cardiologist, because in COVID what happened was the cardiologist had free time. Before that they used to never. So they started coming to the clinic and they got very much interested. So, and even the 2D echo reports, we said we must mention all these things, that is it a progressive lesion? What will be the fatality and all that. So more detailed 2D echo reports also, which give all these details. And then in cardiac cases also now in many complex lesions also there is a better prognosis than before. The surgery has improved. So we need to tell them everything, give maximum information and then we document that in the papers.
Yes, correct. But the counseling must be documented. Then and then only it is considered, because something goes wrong afterwards. Now the patient will give the whole responsibility to the doctors. Now you have not counseled us or you have not told us about the situation. Likewise, it may take place. So we need to have that documentation with. And as Madam said correctly, both signature must be there, patient signature and doctor signature. Then and then only it becomes a valid consent.
Okay.
Just now I got a call from Yavatmal that 21 weeks with a severe cardiac anomaly and one more anomaly. They have taken opinion of neonatologist and a pediatrician. They said the baby will not be surviving, so get for the abortion process. And they were asked to go to civil surgeon. Civil surgeon is not giving permission, that the amendments are not yet applied. This is today's scenario. So we need to counsel these appropriate authorities also from government of Maharashtra. It is very bad situation there. This is the second call in 1 week. One from Satara and now just today I got from Yavatmal.
Okay.
Needs counseling. They don't know the law. The implementing authority don't know the law. That is the bad situation.
Okay. Thank you.
Yes. Thank you, Veena. And thank you, Purnima Sataskar madam. Thank you very much.
It was a pleasure.
Thank you, Purnima madam. Any question for Dr. Kedar? Shraddha, are there any questions for Dr. Kedar, sir?
No.
Okay. I think Chinmay madam has joined in again. Welcome, madam.
Sorry, I just got disconnected. Yeah.
No, madam. So we have finished with the 3 lectures. You can just sum up. It was a very nice presentation, Dr.
I think that in the neonatology lecture was excellent, and then I just had to kind of move out for some time. But see, perinatal awareness is our concept of increasing the other, and I mean the sensitivity of the obstetrician to angina beyond just delivery and PPH and pregnancy related complications. So when we say do no harm to yourself, do no harm to your patient, do no harm to the baby and to the future pregnancy. So if we are aware of all these red flags at different steps in the perinatal period, I'm sure we'll do a better service as we will then become a full perinatal team as opposed to obstetrics alone. So thank you so much, Dr. Veena. I mean, lots of effort that you put in to bring together this program today. And if anyone else wants to say something, we'd be happy to hear.
Yeah, Purnima madam. Final word from Purnima madam.
I think it was a very nice choice of topics which covers, obstetric as well as pediatric as well as medico-legal. I don't think we can run away from medico-legal at any time. It has to become a habit to pen it in such a way, everything which we are writing down, and which rightfully was pointed out by Dr. Mani. So congrats, Veena, and I appreciate the work of the team. I'm sure there must be a team with you who has helped you with all this. And I hope we have more such programs in future together.
Yes, ma'am. We have many in the pipeline, definitely.
Unfortunately, I missed Dr. Chinmay's lecture, which I'm sure was excellent.
We'll keep meeting again and again.
Yes.
We can have the recording from Shield Healthcare, madam. They put it on the website from Shield Connect, and we can send that link to you.
Okay, thank you.
Because I think this is invariably at 12.
Ajay sir believes in documentation here also.
Because Dr. Stalin is very particular. He's giving me all the links. And this is, I think, 12th or 13th webinar we are together, Chinmay ma'am. Correct?
So we're looking forward to many more with you.
Yes, ma'am. True.
Yes.
Just to give knowledge to all the people is a very good job.
Yes.
And selflessly, we are doing that. You, myself, Purnima madam, Veena, and Anuradha madam also have conducted many webinars here. I think we have conducted 37 webinars in last year.
Fantastic.
Under her presidency. Yes.
I know.
Yeah, and thank you, Shraddha, for doing the job very perfectly. She is very good singer, I must say that.
Oh.
Shraddha is a star of our society.
Thank you for the appreciation, sir.
I think, Shraddha, I'll just take a few words to thank everybody in my capacity as a convener. First of all, thanks Dr. Bipin Pandit sir, Foxy Vice President, who took time out from his very busy schedule amidst the Foxy elections to be here and bless our CME today webinar. I would also like to thank Dr. Madhuri Patel madam. She could not join, but yesterday she had accepted the invitation. I am sure she must be busy with all the elections and everything, but definitely we have your support throughout. Thank you, Madhuri madam again. Thank you, Foxy Perinatology Committee Chairperson, Dr. Chinmay Ratha. You're always there. You are always so full of energy, so full of ideas, that definitely that enthusiasm spills over to all the members, and we definitely look forward to having many more such webinars or offline conferences, so that our aim of improving the perinatal outcome for each and every pregnant lady and the fetus goes to the grassroots also. Thanks to our chairpersons, Dr. Purnima Satoskar madam. No words will be enough to actually thank her. She is such a senior person, but she's so down to earth, she's so humble, and then she's always there for us. Anytime you ring her up, she's always there for you. So thank you, Purnima madam. Thank you so much again. Thank you, Dr. Shivani madam. She is our president of the Gynec Society Aurangabad, and she's very enthusiastic, always full of ideas for better CMEs and better webinars. Thank you again. Dr. Lakshmi madam, my senior, my professor, and definitely thank you. Thank you, Lakshmi madam. My faculty, again, Chinmay Ratha madam. We look forward to many more such webinars and offline conferences. Again, I have so many ideas in my mind. I'll just put it across to you and let's see how things work out. Dr. Kedar Savleshwarkar, thank you so much. He was a very late entrant into the race because I just rang him around 2 or 3 days ago. He's a very close friend, always keeps hammering me, ki do this in your labor room, do that in the labor room. And definitely we have things for the better changes we have made. Dr. Ajay Mane, he is a friend, he is a classmate, but definitely with his march towards the Foxy Vice Presidentship, I just have to thank him officially also. Dr. Shraddha, who accepted to be the Master of Ceremonies, thank you to her. And thank you to Shield Healthcare team, Dr. Stalin, Ms. Chitra, Ms. Suchita. Thank you for organizing this, and thank you for putting the Zoom platform and everything. Thank you.
Yeah, just for an information, can I? Sorry, Chinmay, madam, please.
I wanted to thank Dr. Veena specifically because, people said it's very difficult to work as a chairperson, बहुत काम करना पड़ेगा, but I'm really enjoying it because I have this wonderful set of, senior people in my team who actually, they have the ideas, they have the zeal, and they take on and do this. So Dr. Veena, really hats off to you. This entire program was designed by you, planned by you, and executed by you. And I will take credit for it as a chairperson of the Perinatology Committee. But it's really great to have such real nice team members. And we are looking forward to Purnima ma'am's program on 1st of April. So thank you very much, really. And yes, Ajay sir, you were saying something.
Yeah, today only I have completed my recording with the conference. They have recorded my 6 lectures and tomorrow 7th. So they will be having one set of 7 lectures on medical legal. I'll be providing the link. So 7 lectures at a stretch we can hear on the conference. I'll give the link very soon.
Definitely, sir. Thank
you. Purnima
madam,
just for your information, I'm doing this free of cost completely since 18 years. I never charge from any doctor, and I have never helped a patient to lodge a case against any doctor till today.
Thank you, Ajay. You are always there for us. Thank you.
Yes, thank you.
Thank you, sir. Thank you, all of us.
Yes, thank you, Chinmay madam. Thank you. Bye.
Thank you, Veena.
Thank you, madam, for being there today. Thank you so much.
Thank you for the opportunity, ma'am.
Thank you, Shraddha. Thank you. Yes,
thank you.
You're always there, so we are very sure of it. Okay.
Bye.
Okay, bye. Bye.
Bye.
Have a good evening. Bye.